Green. What? How?
Okay. So I wonder if you can see my presentation now.
Yes, we can see the presentation.
Okay, so we'll start now today with some vitreoretinal interface disorders. Can someone describe what can we see here? What's this OCT?
Please, Professor, can you please make the presentation big?
Sorry,
Can
I
you
couldn't
please
hear you.
make the presentation big? The presentation is small.
It's I'm sure I'm sharing it full screen. Can anyone? Does anyone have problems with the presentation?
I think it is full screen at me.
No, doctor, it's a no, doctor, it's
Glory, I suggest probably you can, probably leave the meeting and come back again. I think probably this will solve the problem.
Okay.
Okay. So who can tell me what we can see here in this OCT? Who can give us a comment about what's going on in this OCT?
Disturbed fovea and disturbed fovea.
Okay. Disturbed foveal pit. And what we can notice here, what is this?
Macular hole.
This is a full thickness macular hole. That's great. So what can cause this appearance? What are the causes of macular hole?
ممكن posterior hyaloid traction or
Okay, it can be idiopathic.
trauma.
Okay, or it can be traumatic. Sometimes after the trauma, this macular hole may happen, or it may be myopic. So in patients with high myopia, they may develop a myopic macular hole. Okay. Okay, so the idiopathic macular hole is usually due to abnormal vitreoretinal interface interaction between the vitreous and the retina and the vitreoretinal interface. Can you hear me?
Yes, doctor, we hear you.
Okay,
Yes, doctor.
so there is usually some sort of vitreous traction. If you can see here, this is the posterior hyaloid, and this is the other end of the posterior hyaloid, and they are exerting some traction on the fovea. So the macular hole usually starts by dehiscence between the layers of the retina, and then tissue defect at the outer retinal surface close to the retinal pigment epithelium, and then it progresses to a full thickness macular hole. So if it's still not a full thickness macular hole, it's stage 1. But if it progressed to a full thickness macular hole, it's stage 2 or more. How can we differentiate between the stages? Can you hear me like that, please?
Yes, doctor, we hear you.
Brilliant, that's good. So if it's a full thickness macular hole with the diameter at the minimum area of less than 400 micron, it's stage 2. You can use a caliper on the OCT machine to measure this minimal dimension of the macular hole. If it became larger like that, it's stage 3. If you still can see the posterior hyaloid and the vitreous is incompletely detached, but if it is completely detached and you can see a vice ring, it's a stage 4 macular hole. So let me ask you, when should we intervene? Should we operate on all cases of macular hole, of idiopathic macular hole?
According to the affection of the vision.
Okay.
And the stage of and the cause.
It depends on the stage of the hole. That's the important part. In idiopathic macular holes, we depend on the stage. So which stages should be operated on? Stage 2 or more. So if a patient has stage 1 macular hole, we usually do not operate on them, even if they are symptomatic, because there is a very good chance, up to 50%, that it may resolve on its own. But if it's stage 2 or worse, the spontaneous resolution doesn't occur except in less than 10%. So we operate on most of those patients. So if you have 2 patients with macular holes, one of them has this appearance of the macular hole, and the other one has this appearance of the macular hole. Can you tell me which one has a fresh macular hole and which one has a neglected chronic macular hole? The one with the black and white or the one of the colored one is a fresh one. Is it this one, the colored one, or that one? Which one is the fresh macular hole? How can we differentiate?
I think the colored one is fresh.
The fresh macular hole. That's true, because in fresh macular hole we usually have cystic spaces in the retina, in the nearby retina, and you have swelling of the edges of the macular hole. So the edges at the macular hole are swollen, while in neglected macular hole, those cystoid spaces usually resolve over the time, and the edges of the macular hole will become of normal thickness like here. Which one has better prognosis if you are counseling the patient about surgery? If you have 2 patients, this one and that one, which one will have good chance, better chance of closure after surgery?
Fresh.
Fresh.
The fresh one. So if you see a patient like this, exactly, if you see a patient like that, you'll say, okay, we will operate, but the percentage of closure is lower than, we expect it will be low because this macular hole has been there for some good time. Okay.
دكتور لو سمحت، طب لما البروجنوزيس مش كويس وخلاص بقى الهول عندي يعني يعتبر فايبروز وشرينكد ومش هيرجع لطبيعته، اعمل ايه؟
This is a very good question. So we have some recent advances in the macular surgery for macular hole. In the past, what type of surgery is the classical surgery for the macular hole? If you see a patient like this, what is the surgery for this patient?
It was ILM peeling.
So you do pars plana vitrectomy first?
It was pars plana vitrectomy with
vitreous detachment, induction of, and then ILM peeling. Recently, we changed that, so rather than peeling the ILM, we do what we call an inverted ILM flap. So we, remove the ILM, but we don't remove it completely. We remove this part of the ILM, and we fold it over itself. So it will give scaffold for the retinal tissue to grow back again. Okay? In cases with unsuccessful surgery, we may do what we call an amniotic membrane graft. So you get an amniotic membrane and you tuck it here in that macular hole, or you do what we call a retinal autograft. So you take a part of the retina outside the vascular arcades, outside the macula, and transfer it to and transpose it or transfer it to the macular hole. These techniques, we found that they give good anatomical results, but not necessarily good functional results. Okay, they may work in some patients, but many of the patients will say that we did not appreciate improvement of the vision after the surgery. So it is still advised to have the surgery done in the early phases of the macular hole rather than the late phases of the macular hole. Okay?
لو سمحت يا دكتور، وانا عندي ممكن يحصل بروجريشن للموضوع غير ان هو يقف عند الماكيولار هول؟
This is not common except in myopic macular holes, which may progress to myopic macular hole retinal detachment. So the retina may detach because of the myopic macular hole, but this happens only in myopic macular holes and not in idiopathic macular holes.
شكرا لحضرتك.
Any other questions? عفوا تحت أمرك. Okay, so let's move on to some other vitreoretinal interface abnormalities. Can someone tell us what we can see here? This colored OCT, what does it show?
Vitreoretinal contraction and the steroid membrane attached.
Epiretinal membrane. This is called an epiretinal membrane. Again, this one is called an epiretinal membrane, and it may cause traction on the surface of the retina with this spongiform edema, and we call it vitreomacular traction, or sometimes it is just adherent to the retina without traction, and we call it vitreoretinal adhesion. This is an important new classification of the vitreoretinal interface working group. They classified the abnormalities of the vitreoretinal interface. If the epiretinal membrane is thin, what is the name of that? If it's thin, like this one.
Cellophane maculopathy.
Cellophane maculopathy. If it's thick, and you have a thick membrane over the retina here, what is it called?
Macular pucker.
Exactly, that's true. Okay, so can someone tell me what we can see here on this OCT? We have an
epiretinal membrane pseudo hole.
This is an epiretinal membrane. This epiretinal membrane is giving some traction and thickening of the retina around the fovea. The thickness of the fovea is normal. There is no loss of tissue here. So there is an apparent hole here, which looks like a hole, but actually it's not hole. This is normal tissue, but the retina is edematous on this part and that part, and this gives false appearance of a hole, which is called a pseudo hole. Okay. Okay. So let's move on to this one. What do we see here? So someone can give us a comment on this photo. What is this test? What is this test called?
Retinal pigment epithelium detachment. Neurosensory detachment.
Neurosensory detachment. This is called an OCT scan of the macula. Okay. Here we find that the foveal pit is more or less a bit disturbed, but it's still not completely gone. The retina itself, the retinal stroma itself is normal, but the retinal thickness or the macular thickness is increased due to subretinal fluid. This is called subretinal fluid accumulation. Okay, and this is called retinal pigment epithelium detachment. So this is a neurosensory detachment, while this is a pigment epithelial detachment. Can you guess the condition in which the retina is not having intraretinal fluids? There is no cystoid macular edema like this one, but there is neurosensory detachment and pigment epithelial detachment. What condition can cause this?
CMV.
Age-related macular degeneration.
I don't agree. Yeah, usually in CMV or in age-related macular degeneration, you'll find that there is thickening and abnormality in the choriocapillaris and the retinal pigment epithelium and the photoreceptor line. But here you find that this is more or less normal. So I would think of something else, some other disease. CSR, so central serous chorioretinopathy, can cause this appearance. And there is another important entity, which is the Vogt-Koyagi-Harada disease. Sorry?
Oh, okay. No.
The Harada disease, again, can cause neurosensory detachment and pigment epithelial detachments like that. So if I see this OCT, even without seeing the patient or even without seeing the fundus colored photo or the fluorescein, I would think of either CSR, this is on top of the list, or Harada disease as a differential. But if I look at this one, the difference, the main difference, that there is intraretinal fluid cysts. In addition to that, which type of detachment of that?
Neurosensory detachment.
So there is cystoid macular edema, intraretinal fluid, and neurosensory detachment, subretinal fluid. What diseases can cause this? Give me some examples of diseases that can cause this.
Diabetic retinopathy.
Diabetic retinopathy.
Diabetic retinopathy. Okay. What else?
Vein occlusion.
Vein occlusions. Vascular occlusions. And what else, Dr. Gloria? I didn't hear you.
Irving-Gas syndrome.
Irving-Gas syndrome or a post-operative cystoid macular edema. So this appearance will give me, you know, many things to think about, but at least I can say that this one is not Harada disease and it's not CSR, because usually Harada disease and CSR are characterized by absence of intraretinal fluid. Okay? Do you know what's the name of this grid? So
ETDRS circles.
Exactly. So it's usually superimposed on the macular map, and it gives the thickness of each segment of the retina. Usually the central circle is 1 millimeter thick, and then you have a 3 millimeter thick circle, and then a 6 millimeter thick circle. Okay? So here, what is this? What do you think?
CNV.
This is CMV. As you can see, there is neurosensory detachment. There is what we call tissue pigment epithelium detachment. So here, it's not clear. This is fluid pigment epithelial detachment. Fluid, it's clear, but this is tissue pigment epithelial detachment, or fibrovascular pigment epithelial detachment. So if I tell you that one of those is an OCT of a classic CMV, and the other one is an OCT of an occult CMV. Although this classification is not very important now because we don't do photodynamic therapy, this classification was important at the era of photodynamic therapy, but now classic or occult CMV, they are both treated with anti-VEGF, so this classification is not very, you know, important. But if I tell you that one of these is a classic CMV and one is an occult CMV, can you tell me which is which? A is, this one is
Classic.
What is the classic?
This is the classic and this is the occult. I completely agree with you. The main difference in occult CMV, the CMV is still underneath the retinal pigment epithelium, and only the fluid is leaking and separating the retina. While in the classic CMV, and this is why in occult CMV, it's not very visible, it's not very clearly visible on the fluorescein angiogram because it's covered by the retinal pigment epithelium, which blocks the fluorescence. While in classic CMV, the membrane penetrated through the retinal pigment epithelium and invaded the retina itself. It's causing subretinal fluid and, in addition, intraretinal fluid. Which one of them usually present with better vision? The classic or the occult?
The classic.
The classic, it's more invasive, so it has invaded the retina and it caused more damage to the photoreceptor line. But here, if you can, as you can see, there is still pigment epithelial detachment and neurosensory detachment, but the photoreceptor line here is not very disturbed. So it's usually patients with occult CMV, they have better prognosis, okay, or better vision.
Okay.
Okay, great. So sometimes we see patients with pigment epithelial detachment only, without subretinal fluid. So only subretinal pigment epithelial, whether fluid or tissue detachment. Should we treat them with anti-VEGF or not? If there is no neurosensory detachment, it's only pigment epithelial detachment. Should we start the treatment or not?
No need for injection.
Start the treatment.
No need for injection.
Start.
If there, no, it's not needed, because this may be a soft drusen, a large soft drusen, and it may remain like that for years with causing no problems. The problems will occur only if there is neurosensory detachment or if there is intraretinal fluid. So if there is intraretinal or subretinal fluid. But if it is just pigment epithelial detachment with no fluid, there's no need to start treatment. This should be clear for you. Okay?
يعني حضرتك يا
Can
دكتور
someone
البيشنت
tell
ده
us what?
مش
This one? He has subretinal fluid. So he should be treated. أنا بتكلم لو ما فيش subretinal fluid ده and it's only you find a normal retina with only this pigment epithelial detachment and the retina is flat over the retinal pigment epithelium, the patient should not be treated. But here in this patient, he started to develop subretinal fluid. So he or she should be treated. Okay?
تمام يا دكتور بس انا
Okay.
قصدي عندي سؤالين معلش يعني الفيجن بتاعت
عمرك.
البيشنت هتكون متأثرة هيكون الفيجوال اكيتي بتاعته
Course.
وفيها مشكلة طيب
Course,
الفولو اب
this
بتاعه
patient-
يبقى كل قد ايه؟
This is a very good question. How should we treat those patients? What is the mode of treatment that we use with those patients with wet AMD?
We use injection of anti-VEGF. Several
How can we do
injection
that?
of anti-VEGF.
So we usually start with 3 injections of anti-VEGF, and then you can follow one of the protocols, either treat and extend. So each time you bring a patient and inject, and then leave him for 4 weeks, and then inject again, and leave him for 6 weeks, and inject again, and leave him for 8 weeks, etc., etc., etc. Or you do what is called the PRN, or the treat when needed. So you bring the patient and check if he or she is having subretinal or intraretinal fluid or not. If there is still fluid, you do more injection and then bring him back 4 weeks later, check again with an OCT to see if there is fluid or not. When there is no fluid, you start not to give an injection. You don't give an injection. You bring the patient back in another 4 weeks for another check. If there is still no fluid, you can leave him for another 4 weeks. If there is fluid, you start to inject again. So this is inject when needed. So you rather than over treating the patient, you bring him back again and again and again and do more and more and more OCTs, and you judge whether the patient needs more injections or not according to the presence of intraretinal or subretinal fluid. Okay? Okay? تمام دكتور ولا في أسئلة تاني؟
تمام شكرا لحضرتك يا دكتور شكرا.
Okay, so what is this investigation?
This is an ocular ultrasound.
This is an ultrasound. Okay. What type of waves or what type of ultrasounds we can use with our patients? What is the type of this ultrasound? Is it A scan ultrasound or B scan ultrasound? Don't look at this.
B scan.
This is a B scan ultrasound. Okay, so if it's an A scan ultrasound, you find that there is a vector here. A scan is good to measure the axial length and to measure the reflectivity. But B scan, it's good to give some idea about the morphology. We should know that if there is a mass, for example, a tumor or something like this, we need to scan in 2 directions at least. So we have here, as you can see, this is the probe of the ultrasound. And this indicator usually corresponds to the superior part of the screen. Okay? So if I'm holding the probe like that, and this is what's showing on my screen, this should be the superior or the temporal or the inferior retina. What do you think this part will be?
It will be the superior retina.
This is the superior retina because it corresponds to that part. What if I'll hold the probe like that with the mark here looking at that aspect? So this will be which part of the eye?
Temporal retina.
This will be the temporal retina. When I find the mass, I need to scan at least in 2 directions. So I scan it while in the vertical direction like that to get the height of the mass, and then I shift this one horizontally and start to move the probe superiorly and inferiorly to get an idea about the width of the mass. Did you get that? Did you get the idea? So when the probe is directed like that with the mark superiorly, I move it to the nasal and the temporal sides, and I measure the vertical height of the mass. The superior part of the mass will be here, and the inferior part of the mass will be there. Then I need to rotate the probe and bring the mark temporally or nasally. And at that time, I move the probe superiorly and inferiorly. And when there is the mass, this will be the width of the mass. This will be, for example, temporal, and this is nasal, and this is the width of the mass rather than the height of the mass. Did you get that idea?
Yes,
Okay.
Yes,
Professor.
doctor.
Okay. So if I have this one, this is the B scan, and this is the A vector. What's very important is to differentiate between retinal detachment and posterior vitreous detachment. Can someone give me the differences between them? How to, if you are operating on the machine, what to look for in order to write your report, whether this is a vitreous detachment or this is a retinal detachment. Why this is important? Let's imagine a scenario that we have a diabetic patient. This diabetic patient developed a sudden drop of vision in one eye, and you try to examine the fundus. You can see absolutely nothing because of the hemorrhage. You are not sure if there is detachment behind this hemorrhage or there is no detachment. If it's vitreous detachment, then probably you will follow the patient up, and the hemorrhage may resolve over the time. If it's retinal detachment, then probably you want to intervene early. This is why it's very, very important to differentiate between the two conditions. So what are the differences between vitreous detachment and retinal detachment? Who can give us some clues? So I'll give you a clue.
ممكن الاتاش للأوبتيك نيرف.
Exactly. So as you can see here, the retina, if you look here, even if the retina is detached, it will remain attached to the optic nerve head. But if the vitreous is detached, imagine that the vitreous is detached, there will be a vice ring, but the vitreous is completely detached from the retina and not attached to the optic nerve head. This is why in retinal detachment, if you find that it is attached to the optic nerve head like this, then this is suggestive of retinal detachment. If the optic nerve head is not attached to that, then it's suggestive of vitreous detachment. This is number one. What's number two? If I look at this part, look at that part, what's the difference between them? I'm giving you a clue. Which one has higher reflectivity? Which one is thicker? The vitreous, the posterior?
Has higher reflectivity.
Higher reflectivity, because if you are operating, if you are doing vitreoretinal surgery, you'll find that the retinal tissue is very thick in comparison to the posterior vitreous. So it will reflect more of the ultrasonic energy than the vitreous. This is why it will appear more whitish, and it will have higher reflectivity, very similar to the reflectivity of the sclera on the A vector. On the other hand, the posterior vitreous will be less reflective, so it will be grayish rather than whitish, and it will have less reflectivity on the A vector than the sclera. Okay? This is clear for you? We have something which is called the gain. The gain is like the volume button of the radio. So you can increase the gain or lower the gain. If you are increasing the gain, you are increasing the ultrasonic power that you are, producing. So it will be, more reflected. But if the structure is persistent on lowering the gain, this means that it has very high reflectivity. So which one do you think it will persist on lowering the gain, the retinal detachment or the vitreous?
Retinal.
So again,
Retinal.
that's true. If I will decrease the reflectivity usually to something like 60, you'll find that this one is, disappearing and becoming not very visible. But the retina will persist on lowering the gain. Okay, another clue. If you ask the patient while he is having the probe on the eye to move the eye to the right and to the left, which one will show more mobility on kinetic examination, the retina or the vitreous?
The vitreous.
The vitreous, because the vitreous is liquefied, so it will move easily. You find that, this posterior hyaloid is actually moving or dancing while the patient is moving the eyes to the right and to the left. While the retina, especially if it's neglected, retinal detachment will become fibrosed and very stiff, and it will not show mobility on kinetic examination. So those are the differences. Attachment to the optic nerve head, A vector, whether it has high reflectivity close to the sclera or less than the sclera, reflectivity less than the sclera, persistence on lowering the gain, and kinetic mobility. Okay? What is this? You are
Lattice
examining.
degeneration.
This is a lattice
Lattice
degeneration.
degeneration.
If you see the patient, if you see this in an asymptomatic patient, is it necessary to treat it?
No.
No, there's
Just
a bit
follow
of
up and the follow up.
controversy here. Exactly. Many retinal specialists will advise that this is not needed to treat this patient. While if the patient is symptomatic, he or she are having symptoms of PVD or retinal detachment or in the other eye of the patient, or for example, the patient will have a refractive surgery and it will increase the risk of retinal detachment, we may want to treat that. How we treat it? How do we treat it? How can we treat it?
With argon laser.
Yeah, what is that called? It's called argon laser retinopexy.
Retinopexy.
So you do a retinopexy around the break, around the lattice degeneration. What's the philosophy of doing this laser treatment? How will it, treat the lattice degeneration? What's the idea? Why do we do it?
It will prevent
To prevent
retinal detachment.
fibrosis induced.
How will it? Exactly. It will create strong chorioretinal adhesion at the edges of at the areas of the laser treatment, so that if the patient will develop a hole or a tear on the lattice degeneration, it will not progress. It will act as a barrier of strong adhesion between the choroid and the retina that will prevent the subretinal fluid from dissecting and causing worse retinal detachment. Okay. Where does the break usually happen? At the anterior edge of the lattice degeneration or the posterior edge of the lattice degeneration? Let me give you a clue. So if you have a patient like that, is it adherent to the posterior border of the lattice, the one close to the retina? Sorry, the one close to the optic disc, or to the anterior border of the lattice, the one close to the ora serrata? You see a patient like this. This is a superior break. Where is the vitreous adherent? To the posterior edge or to the anterior edge? What do you think?
To the posterior edge.
To the posterior edge of the lattice. So usually the adhesion is stronger at this border, and when vitreous detachment happens, usually it tears along this border, and you find that the lattice is present on the break itself and not on the detached retina. فهمتوني يا شباب؟ Did you get this
لا
point؟
دكتور.
ما فهمناش. نقول تاني. We will find usually that the lattice is present on the tear. So we have a horseshoe tear. You will find that the lattice, it's not present on the normal retina. It's usually present on the tear. Why? Because the vitreous is tightly adherent to the posterior border of the lattice and not to the anterior border. If it's adherent to the anterior border of the lattice, you'll find that the lattice will be here. لانه ماسك في الانتيريور بوردر بتاعه, so the tear will happen at this, but this is not true. Usually we know that the strong adhesion of the vitreous is usually to the posterior edge of the lattice, and we frequently find that the lattice is present on the edge of the flap tear. وضحت؟ ولا نقول كمان؟
لا واضح
حد مش
دكتور.
فاهمها؟ حد مش فاهمها؟ انا عارف انها صعبة شوية, بس حد مش فاهمها؟ اوكي؟ Okay. So you have a patient who presented to you in the ER with sudden flashes and floaters, and you examine the fundus and you find something like this. What is this?
Horseshoe tear.
What is this?
This is a bridging vessel.
It's called a horseshoe tear on a bridging vessel. Usually this patient will present with aggressive floaters due to the associated vitreous hemorrhage due to that. This patient has detachment or not? Does this patient have detachment or not? I'll say yes. The area, the edema of the retina here points to that this area is detached. If the patient developed detachment, what will be the treatment? He or she will need to have surgery done. Okay? Surgery, either scleral buccal, pneumatic retinopexy, or vitrectomy, whatever. But if you see a tear without detachment, how can we treat that?
Pneumatic retinopexy.
Oh, no, 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 no. There's no need to put the patient to surgery. How can we treat that? What is this?
Laser
Okay.
retinopexy.
Laser?
So you do laser treatment around the break, especially the anterior edge of the break, because this is the area from which the fluid will usually leak. And if you do that, you will create strong chorioretinal adhesion. So even if that area will detach, the fluid will not be able to pass and detach the remaining part of the retina. Okay, this is why it's very important to have a very good examination of patients presenting with flashes, with recent flashes and floaters. So the earlier the complaints and the symptoms, the more probability of having problems. If the patient will come to you and say, I have flashes and floaters for 2 or 3 years now, usually you will not find a break, because if they had a break, they would have detached by that time. But the main problem is with patients who presents with, for example, 2 or 3 days history of flashes and floaters. You need to examine them thoroughly to make sure that they don't have retinal breaks. Okay? تمام شباب? Let's move to that one. So the vitreous detachment, the best description about the vitreous detachment was given by Dr. Samir Al-Baha when I was an undergraduate student. You know, when you do the yogurt and you leave it in the fridge for 2 or 3 days, and then the yogurt start to separate and come to the center, and you have some fluid at the edges, this is exactly what happens in vitreous detachment. علبة الزبادي البلدي بتاعت زمان، لما الزبادي يقعد يومين 3 فيكش ويبقى الedges فيها ميه. The collagen will shrink and detach from the retina, and the edges will be filled with fluid. If there is a retinal tear, that fluid will start to pass between the retina and the retinal pigment epithelium. So the plane of cleavage, it's between the neurosensory retina and the retinal pigment epithelium. It will start to dissect its way, and by the gravity, it will come down. And especially if it's a superior break like that, you will have a small break here, but an extensive area of detachment. Okay? Again, this is a very characteristic OCT. If you see an OCT like that, think about retinal detachment, and the break will be somewhere here. And the fluid is dissecting the macula. Is this a macula on or a macula off detachment?
It's a macula off.
So it's a macula off. This macula is detached, so it's a macula off. This one, what do you think? Is it a macula on or a macula off detachment?
On.
The macula is still on.
The macula on detachment with a large superior detachment. This patient should be operated on the same day or maximum next day, because if you will leave him for 1 or 2 days, the fluid will dissect its way and will detach the macula. What's the problem if the macula is detached? Why do we consider?
Outcome?
Exactly. So if the macula is detached, the patient will have a poorer visual outcome. So the final visual acuity will be worse, and the metamorphopsia will be worse. حد مش فاهمني شباب؟ Sometimes you may have 2 or more retinal breaks close to each other. The vitreous is adherent to this point, and when it detaches, it tore the retina here, and the vitreous is adherent to this point, and again it caused a tear at that part of the retina. And those 2 tears started to leak fluid to the subretinal space with subsequent retinal detachment. Okay?
Please, Professor, how to know where is the tear?
This is to know where the break is. Is this what you was going to ask about?
Yes, yes, yes.
What do you know the name of those rules? Linkoff rules. Okay. So usually remember that the fluid by gravity, it will dissect its way down. So if you have a superior retinal detachment, try to look at the superior part of the retina and try to look at the edges of the, if you have, for example, a detachment like that, try to look at the superior part of the retina. If you have an inferior retinal detachment like that, try to look either at the edges of the superior part of the detachment or at the inferior retina close to the area of higher level of fluid. So look, this is, for example, temporal retina, this is the nasal retina. Start to think first, where is the higher level of fluid here. So I should focus on that part of the retina. This is a very common site because it will leak fluid downwards like that. But again, you may find that the break is somewhere more inferior, but towards the side of the higher level of the fluid. If the fluid is more or less equal on both sides, think about 6 o'clock. And usually those breaks cause a very slow progression of the retinal detachment. We are more worried about superior breaks. Those are the ones which usually progresses very quickly within few days. If you have a bullous detachment, sometimes you may find a patient with an inferior large bullous detachment, and you start to think, I will look for the break here or there near the bulla. No, no, no. Usually those patients have a superior detachment. Either the superior retina will be detached like that, or you may find that the superior retina is normal like that. Try to look at the very far periphery. You'll find a track of fluid that is leaking that fluid to the inferior retina and causing this bullous detachment. So whenever you find inferior bullous detachment, always look for the break above the horizontal meridian. Look for it up. Okay? حد مش فاهمني؟ Any problems with that?
شكرا.
The blue part is the detachment and the red part is the retina.
Exactly, exactly. The blue part is the detachment and the red part is the attached retina.
And the white is the optic nerve?
The white is the optic nerve. Yeah, exactly.
Okay.
Okay?
Yes, Professor.
So let's move on. You know what's the name of this operation? It's called pneumatic retinopexy. So the main idea that we want to do a minimally invasive retinal detachment surgery. We don't, because each step has its potential complications. So you want to solve the problem of the detachment with the least possible intervention. So the operations that we can use either scleral buckle, pneumatic retinopexy, or vitrectomy. In pneumatic retinopexy, the main problem that if you have a detachment like that, just a second, if you have a detachment like that, there's a single break, the retina started to detach, you want to do laser treatment for the patient the retina will not take the laser because the laser should be absorbed by the retinal pigment epithelium to produce the thermal effect and do the photocoagulation. If the retina is detached, there will be no uptake of laser. So you want to flatten the retina first and then do laser treatment. This is what we do here in this type of pneumatic retinopexy. So you may inject gas. The gas will close the break, prevent the fluid from leaking to the subretinal space, and you position the patient so that the gas bubble is closing the break. Few days later, you'll find that the retina will become, or few hours later, the retina will become flat, and you can do laser treatment on attached retina. This is a form or a technique of pneumatic retinopexy. The other technique is to do cryotherapy from outside. The cryo can be done even on detached retina, and it can produce chorioretinal adhesion exactly like the laser. But the advantage that it can be done on detached retina. So you do the cryotherapy first, and then you inject the gas later to close the break and allow the retina to settle back so that the cryo will heal and close the break. So either way can work. You can either inject the gas first to flatten the retina and do laser treatment afterwards. This is called pneumatic retinopexy. Or you can do cryotherapy first and then inject the gas to flatten the retina and allow healing. And again, this is called pneumatic retinopexy. Two different techniques of the same operation. Okay?
same session ولا بعدها بقد ايه؟
ايه هو اللي في same session؟ The cryotherapy are done on the same session. The cryotherapy and the gas are done on the same session. So you do the cryotherapy first, and then you inject the gas.
لا لو
The
عملنا
laser. Yes. Yes.
laser بعد
The laser
laser.
you don't need the pars plana vitrectomy?
No, here we do not do pars plana vitrectomy. We inject the gas only, and then we do the laser either few hours, but usually it's 24 hours later. You give some time for the fluid to be absorbed, and then you do the laser treatment next.
تمام.
But
Okay.
how did you inject the gas?
Exactly like how you inject an intravitreal injection of anti-VEGF. It's more or less the same, but rather than putting anti-VEGF in the syringe, you put purified gas. We don't use air because we want something to stay longer inside the eye. So we use one of the gases, is either SF6, 6-sulfur hexafluoride, or C3F8, which is perfluoropropane, or C2F6 perfluoroethane. Those usually stay in the vitreous for longer time than air. Okay. Any problems with the pneumatic retinopexy?
And what is the amount of gas to inject?
Usually you inject 0.3 millimeter of gas. Okay. And we may want to do some paracentesis to decrease the intraocular pressure so that when the gas will expand, it will not cause a sharp rise of the intraocular pressure. Okay, okay, شباب. Okay, this is how the cryotherapy is done. So this is the break. You do the treatment to the nearby area of the retina. You should not aim at treating the break itself, but you want to create chorioretinal adhesion at the edges of the retina. This is how it looks like when you are doing fresh cryotherapy. It will be whitish like that, and then when it heals, it become, you know, a scar like that. And the scar here, there is strong adhesion between the retina and the choroid, so the fluid cannot dissect the retina and detach the retina from here. You are using an indirect ophthalmoscope to look, and you direct the probe from the outside of the sclera to the area of the break. You find it on your indentation hub, and you start to apply the cryotherapy. تمام شباب؟ حد مش فاهمني؟
تمام يا دكتور، بس لو سمحت في حالة الكرايو يا دكتور، أنا كده مش باخد اريا كبيرة من الريتنا، لأن أنا مش يعني مش محدد قوي زي الليزر أو يعني السبوت بتاعته مش كبيرة.
لا، انت السبوت بيحددها حجم البروب يعني. the spot is the cryotherapy size is determined by your spot, the size of the tip of your cryoprobe, and by how long you apply the cryotherapy. The longer you apply the cryotherapy, the larger the ice ball that you will get. So we start to apply the cryotherapy just till having the ice ball starting to appear here, and you stop. And as you can see, the cryo mark is very similar in dimension to the laser treatment done here, for example. It's more or less very comparable to this one, because when you start to see the ice ball, you stop the cryotherapy application. Okay?
Okay, doctor.
Okay, so this is how it looks like. We have a break here. Just a second. We have a break here. Where is my... Just a second, let me get my pointer. We have a break here. This is the break. You indent with the cryo till reaching the area of the break, and then you start to apply the cryotherapy. This is how it looks when it starts to form. And then when you are happy that there is a good size ice ball that it's covering the break, you stop applying the laser, and it will thaw away like that and will start to heal to end up with something like this. Okay? This is how we do the drainage of the subretinal fluid in cases with, if we will put a scleral buckle, we may want to do what we call drainage of subretinal fluid. So you cut through the sclera in order to get access. Sorry? In order to get access to the subretinal fluid, you dissect through the sclera so that the fluid will drain. Of course, the drainage has some complications, that you may injure a choroidal vessel and cause some subretinal or intravitreal bleeding. So if you can avoid it, it's better. But sometimes you want to make sure that the break is closed and there is no subretinal fluid. So you may want to do this drainage of subretinal fluid. Just a second. So you cut through the sclera, and then you use an insulin syringe to separate the lips of the sclerotomy. This is called the sclerotomy. As you can see now, there is egress of fluid from the sclerotomy. This is called the subretinal fluid. This is the fluid that detaches the retina from the underlying retinal pigment epithelium. When you detach it, when you remove that, the retina will become flat, and you will the pressure inside the eye will be less because some of the intraocular content has gone outside, and then you can apply or you can put the scleral buckle later on. Okay, you can put either a silicone sponge like that one or a band and a tire like that one. The idea of the buckle that it pushes the sclera inwards, so it will resolve the vitreous traction on the brake. So you have the vitreous causing some traction on the brake. You want to relieve that traction, so you push the whole sclera inwards so that the brake will become closed in a better way. فاهمني؟ Okay, فهمنا فكرة السكليرال buckle? And you use that if you believe that the pneumatic retinopexy will not be enough to close the brake. You want to do a scleral buckle at that time. Okay?
يا دكتور يعني انا ممكن اعمل دي في حاله ان انا يبقى عندي سنجل بريك او سنجل.
Yeah. If you believe that it's a large break, it will not be properly closed with pneumatic retinopexy alone, you may want to do a scleral buckle. It will take more time, more steps, more risk with the surgery, but you always weigh the risks and the benefit of each step. So if you believe the break is small and it can be closed with pneumatic retinopexy, don't do extra steps, don't do scleral buckle. But if the break is large or you have multiple breaks or you believe that the patient will not position properly, then you may want to do scleral buckle. تمام؟
امتى ما ينفعش تعمل كده بكر؟
Very good question. What are the indications of vitrectomy? ده السؤال انت اديتني كلام اللي انا عايز ادور عليه. What are the indications of vitrectomy in retinal detachment? So if you have a giant retinal break, it's very difficult to do or almost impossible to do scleral buckle. If you have a posterior location of the break, so if this break is going almost to the macula and very close to the optic disc, you cannot put a scleral buckle to support that. The scleral buckle will support this area, but it will not support the posterior extent of the break. So again, posterior breaks are more, are more of an indication to vitrectomy. Or if you have a PVR, the PVR, the proliferative vitreoretinopathy, is some sort of fibrosis that happens over the surface of the retina. So if there is PVR, you want to go inside the eye, remove the vitreous, peel the PVR membranes first to make the retina more relaxed, and then treat it with vitrectomy. Scleral buckle will not be able to address the PVR. So if there is a significant PVR, this is an indication of vitrectomy. Did this answer your question?
تمام شكرا.
Okay.
Please, doctor, what is meant by sutureless buckle?
By what, sorry?
Sutureless scleral buckle.
Sutureless scleral buckle. This is a new term in which, rather than, just a second, rather than putting a buckle and suturing it like that, you may want to dissect the sclera, and then you go with a cannula to the space between the sclera and the choroid, and you inject viscoelastic material. The viscoelastic material will cause the choroid to bulge, and it will give the effect similar to the scleral buckle. Of course, it will absorb over the time, but it will take a bit of long time to be absorbed. By that time, the healing has occurred at that area. This is called the sutureless buckle.
Thank you.
You're welcome. Okay, so the idea of the vitrectomy is to remove the vitreous first, and then go inside and remove the subretinal fluid from within the eye. You don't do a sclerotomy like we did in scleral buccal surgery, but you remove it either through aspiration through the break or through what we call a posterior retinotomy, a posterior drainage retinotomy. So when you will inject air, it will push the fluid posteriorly. You either go through the break with the cannula and absorb the fluid, or you use the diathermy to make an opening. Sorry, an opening close to the optic disc, so that the fluid will be milked by the air and you absorb it close to the optic nerve head. And then you do laser treatment on the break, and you put a vitreous substitute, either a gas or a silicone. It's like when you are building a new building and you put the concrete inside, you need to put a support to the concrete till it becomes hard. Again, if you do the laser treatment and you will not put a vitreous substitute, the fluid will dissect the retina through the tear again, and the laser will not heal. You need to put something to stop the fluid from passing here till the healing occurs. So you either inject gas or you inject silicone oil. Okay.
according to what
مش سامع حضرتك بتقول ايه؟
according to what الجاز or silicone الchoice حسب
according to several things. If you believe that there is a high probability of PVR, like for example giant retinal breaks, you go more with the silicone oil. If the patient wants to travel with aeroplane early after the surgery, you want to go for the silicone oil because it's contraindicated to do air flights till the gas is absorbed. عارفين ليه? You know why?
يحصل له expansion تقريبا.
Expansion, elevation of intraocular pressure, central retinal artery occlusion. If the patient is one-eyed patient, then you may want to use silicone oil because the gas usually will block the vision until it is absorbed. If the patient is one-eyed patient, he or she will have very difficult time being unable to see with either of both eyes. Okay, so those are the indications in which we prefer to use silicone oil. The main advantage of the gas is that it doesn't need a second operation to be removed. On the contrary, the silicone oil needs a second operation to be removed. So you weigh the risks and the benefits, and accordingly you decide whether to go for this or to go for that.
سيليكون اويل يا دكتور بشيله بعد قد ايه؟
Very good question. So you may remove it 4 weeks after the surgery, or you may leave it for 2 weeks after 2 years after the surgery, up to 2 years after the surgery. In patients who has high probability of redetachment, you may want to leave it for some time, taking into consideration that the patient needs a strict follow-up probably every 2 to 3 months to make sure that it's not causing complications. What are the complications of the silicone oil? If the patient has silicone oil for a long time, cataract formation, glaucoma. What else? Glaucoma, secondary glaucoma. What else? Emulsification and having an inverted hypopian appearance. Band-shaped keratopathy if the patient is aphakic, okay, etc. So it has some problems. It cannot be left for good. You leave it for some time, and then the mean time to leave the silicone oil is 6 months. But sometimes we may want to remove it earlier or later according to the situation. Okay. So this is.
بعد اذن حضرتك بس سؤال غريب شويه بس هو جه في بالي يعني انا في الجاز بيحصل له ابزوربشن والحجم بتاعه بيقل وخلاص. طب انا في السيليكون لما بشيله يعني بشيله كله على بعضه العين بترمي تاني.
It will be replaced with balanced salt solution or ringer solution at the end of the operation. نفس اللي it's exactly the same like when we do vitrectomy and we don't use a vitreous substitute. Sometimes the patient is presenting with a vitreous hemorrhage. You remove the vitreous, you remove the hemorrhage, you find everything is okay. You don't need to use a vitreous substitute. You leave the patient with the vitreous cavity filled with fluid, either balanced salt solution or ringer lactate solution. And over the time, this is absorbed by the body and it's replaced by aqueous humor. Okay. Okay. So this patient has what we call the shifting fluid. If the patient is, lying on, is sitting, he will have the fluid over the inferior retina. If the patient is lying on the back, he will have the fluid shifted upwards. What is the cause of that? What is the type of detachment characterized by shifting fluid, especially if the patient has a large choroidal melanoma like this one?
Exudative.
This is the second type of retinal detachment, which is called the exudative retinal detachment. Exudative retinal detachment means tumor till proved otherwise, either a choroidal melanoma, choroidal hemangioma, something like this, and it is characterized by shifting subretinal fluid. Okay. So what is this? The third type of retinal detachment. What is that?
Tractional.
This is tractional retinal detachment. What is the main cause of tractional retinal detachment, for example, in this patient?
BTR.
Diabetic retinopathy, exactly, advanced diabetic eye disease. How can we treat this patient?
vitrectomy.
Vitrectomy.
Removal of the epiretinal membrane.
How can we remove the epiretinal membrane? Should we peel them, or how should we remove them? What will happen if we will peel them? Like we peel an epiretinal membrane, for example.
If you peel it, you will distort the photoreceptor.
Actually, the retina in those patients is very atrophic because of the ischemia, and it's very thin. And if you will peel the retina, the strong vitreoretinal adhesion will end up causing retinal tears, which will, make things much more difficult. The patient will start with a tractional retinal detachment and will end up with a combined tractional rhegmatogenous detachment. So we do another technique which is called, what's the name of the technique that we use when we use scissors to separate, to cut at the plane between the vitreous and the retina?
Retinotomy.
Retinotomy means that you cut the retina itself. Here we find the plane. It's exactly like when you for example, slaughter an animal and then you start to remove the skin of the animal. You find the correct plane between the flesh and the skin, and you start to separate. It's exactly the same. You find the plane between the vitreous and the retina, and you start using scissors to cut, and remove the vitreous and the proliferations. It's called the delamination. Okay, delamination. There is another technique called the segmentation. In the segmentation, you use vertical scissors, and if there is adhesion between this point and that point, and the adhesion of the membrane to the retina is very thick, so you cannot separate the membrane from the retina, you cut the membrane here so that this point will relax and not be pulled towards that point. It's usually done with vertical scissors rather than horizontal scissors. فهمتوها الحتة دي ولا صعبة؟
تاني لو سمحت بعد إذنك.
تاني, if you use horizontal scissors and we separate the membranes from the retina, this is called delamination. So you delaminate the posterior highlight from the retina using horizontal scissors. If the adhesion is very strong and you cannot delaminate it, go and segment it. Segmentation is done with vertical scissors. So you cut this membrane into pieces so that the pieces are not pulled together, and this will relieve the traction. This point will relax a bit like here, this point will relax here, and this will relieve or decrease the traction a bit. Okay?
Okay, doctor.
Okay, so this will conclude my lecture today. Do you have any other questions?
Please, doctor.
Yeah.
Yes, I still have a question about the pneumatic retinopexy.
Yeah.
The cryotherapy is part of the pneumatic retinopexy, or there are two things different, the pneumatic retinopexy and cryotherapy?
And the cryotherapy. So
yes.
The cryotherapy is one of the modes of treatment that can be used in pneumatic retinopexy. As you can see here, the idea pneumatic retinopexy means that you use air. Pneumatic means air or gas. Retinopexy means that you fix the retina or you glue the retina, okay? So you can glue the retina either with cryotherapy like this one, okay? Or with the laser treatment. And in both conditions, you will inject gas, either if you do the cryotherapy, so you do the cryotherapy first and then you inject the gas second. Alternatively, you can inject the gas first, and when the retina becomes flat, you can do the laser retinopexy second. Okay? So the cryotherapy can be used in pneumatic retinopexy, or it can be used in scleral buckle. So in scleral buckle, you can do, again, cryotherapy, but the main difference is you will add a buckle at the end. So you do cryotherapy first, and then you drain the fluid and put the scleral buckle at the end. This is the difference. Okay, so the cryotherapy can be used either in pneumatic retinopexy or in scleral buckle surgery. Okay.
Okay, thank you.
Any other? You're welcome. Any other questions, شباب؟
دكتور
معلش في اللاتس ديجنريشن.
طب ثانية واحدة، أسمع الدكتور الأول عشان هو ابتدى الأول. يا دكتورة معلش، قول لي يا دكتور.
البي في دي بيعمل فلاش في اللايت برضه؟
البي في دي characteristically can PVD is posterior vitreous detachment can cause flashes and floaters. Those are the classic presentations of the PVD. Any patients with recent complaint of flashes and floaters should have a full dilated fundus examination to check if he or she has retinal breaks or not. And if there is retinal breaks on attached retina, it should be treated by laser retinopexy. If the patient will start to develop detachment, then he or she will need to have retinal detachment surgery, either pneumatic retinopexy, scleral buckle, or vitrectomy according to the extent of the detachment. تمام؟
اوكي.
دكتورة اتفضلي.
حضرتك قلت في اللاتس ديجنريشن بيبقى الفيتريس لازق posteriorly، فهو لو حصل بريك هيبقى يعني anterior ولا برضو في الحتة اللي الفيتريس لازق فيها؟
ثانية واحدة، خلينا نجيبه عشان نراجع تاني مع بعض. بصي يا ستي، الفيترس بيبقى strongly adherent to the posterior border of the lattice. The posterior border means the border close to the optic disc and not the border close to the ora serrata. And if vitreous detachment will happen, it will separate easily from these parts of the retina, but it will come to that part and it will not be able to separate because it's strongly adherent to the retina. So it will pull and pull and pull and will end up causing a tear at that part. And you will find that the lattice is present on the flap of the tear. So if there is the tear here, this area undergone normal separation of the vitreous from the retina, but at that edge, the vitreous is very strongly adherent to the retina. So it pulls and it cannot separate from the retina, pulls and it cannot separate from the retina. So it will pull and tear the retina at that part, and you find the lattice degeneration is present over the flap of the tear. So this is called the flap of the tear. You find that the lattice is present over the flap of the tear rather than over the retina itself. Okay, did this answer your question? واضح؟
تمام. تمام.
Any other questions?
دكتور بعد إذنك، في حالة الكرايو أنا ليه ما دخلتش بكانيولا وسحبت الفلويد وعملت ليزر في نفس الجلسة بدل ما أحقن جاز
life is not that simple. احنا لا، في من ضمن الحاجات اللي ممكن تتعمل ان انت تعملي drainage of subretinal fluid وتعملي ليزر. بس المشكله لا، when you drain the subretinal fluid you are faced with two problems. First of them is the hypotony, so the globe will, fluid is trickling outside the eye, so the eye will become very hypotenuse, and this hypotony will usually cause the pupil to close. So after drainage you find that the pupil will become narrower and it's not easy to do the laser treatment. The second problem that with the drainage you'll find that there is dispersion of pigment cells from the retinal pigment epithelium and the choroid, which usually make the vitreous less clear. It will become more turbid. So it's not easy to do, technically it's not easy to do the laser treatment after drainage of subretinal fluid. Alternatively, we try to get rid of the subretinal fluid by the retinal pigment epithelium without drainage first, and afterwards we do the laser treatment. تمام؟ هو نظريا ممكن لكن technically صعب.
تمام، شكرا لحضرتك.
Any other questions؟ تمام.
هو ممكن سؤال بره المحاضرة بعد إذنك؟
طبعا.
بس هو في سؤال يا دكتور لو سمحت، وانا لو عندي تروماتايزد كورنيا اقيس لها البريشر ازاي؟ بايه؟
traumatized cornea. بصي، هي if it's a corneal wound the pressure should not be measured. فاهمه ازاي؟ لكن في الحالات اللي هي بيبقى فيها corneal scarring في حاجات اجدد بقى اللي هي زي الاورا اللي هي الاوكيولار ريسبونس انالايزر والحاجات دي ممكن to be used، وحتى مع الحاجات دي it will not be 100% accurate.
يعني يا دكتور انا جاي لي بيشنت وعنده رابشر جلوب او عنده يعني عندي تروما في الاي في
Rupture
الاي
globe
عموما.
should never have the eye touched with a tonometer or something like this. Okay. انت ممكن تحسيه very gently digitally ولو انت if you are sure that the patient is having a rupture globe, if you can see the wound in front of you, you should never press the eye with either with your hand or with the machine, because you may cause prolapse of the intraocular content.
تمام شكرا.
اوكي دكتور كان عايز يسأل حاجة. ها طب قولي
تمام.
دكتور الأول. ماشي قولي.
لا بس هو كان في حالة يا دكتور انا عندي سنترال ريتينال فين اوكلوجن، بيحصل عندي من الكومبليكيشن بتاعته ان انا يحصل عندي نيوفاسكولار جلوكوما. يعني طب في السنترال ريتينال ارتي اوكلوجن ليه مش مشهور مع ان الاسكيميا فيه اعلى؟
اوكي لأن الريتنا بتبقى بيرند اوت وبالتالي مش هتطلع فاسكولار اندوثيليال جروث فاكتور. المشكلة لما تبقى الريتنا اسكيميك but not burned out. فاهمة ازاي؟ دي اللي ساعتها بنخاف منها. يعني لو انت موتيها خالص، انت لما تشوفي الهيستولوجي اوف patient with central retinal artery occlusion هتبصي هتلاقي ريتنا اتروفيك خالص. there is damage and death of the neurons and thus it doesn't produce retinal pigment epithelium. But if you look at the OCT of a patient with central retinal artery occlusion, you will find that the retina is edematous. So it's still producing vascular endothelial growth factor. تمام؟
تمام.
دكتور كان عايز يسأل حاجة.
ايوه في السي ان في
اتفضل.
اعرف ازاي انه اكتف من inactive؟
Okay, very good question. Usually we depend on the OCT. If there is evidence of intraretinal or subretinal fluid, this is taken as an indication of activity of the CMB. Other clues will include the vision of the patient. So you'll find that in AMD clinics, they will do what we call the ETDRS letters, and they will count how many letters can the patient see, which translates to the visual acuity with Snellen's or with whatever chart you use. If there is evidence of worsening of the vision, this is an indication that there is activity. So if you bring the patient, as we said, every 4 weeks to see if there is activity and does the patient need injection or not, you do two things: check the vision and do an OCT and check it carefully to see if there is evidence of subretinal fluid or not.
اوكي ماشي شكرا.
عفوا. Any other questions? Okay. Best of
Thank
luck.
you.
I'll try to download the lecture and upload it on YouTube and share the link with you. And all the best with your exams إن شاء الله.
ان شاء الله. شكرا.
إن شاء الله تصبحوا على خير. شكرا. Good night.